This is it. Hello, I'm Philippa. Welcome to Moving Through Menopause. Joining me today is Gabriela Rosa. Gabriela is a fertility specialist and a reproductive health educator. She's also a Harvard University awarded scholar. So welcome to the podcast, Gabriela. It's wonderful to be chatting with you today.
Hi, Philippa. Thank you for having me. It's really lovely to be here.
You're very welcome. Gabriela's created the world's first entirely virtual and holistic health facility dealing with fertility issues. Gosh, that's a bit of a mouthful, isn't it? Facilities and fertilities. And this is the Rosa Institute. So, I mean, this is an amazing achievement to be working across the world, helping women who are hoping to conceive and have that, that amazing experience of becoming a parent. She's known for identifying and treating the biochemical obstacles to conception. And so today, here on Moving Through Menopause, we are talking about the intersection between menopause and reproduction. And so that phase of our lives called perimenopause, when honestly, to be perfectly frank, it's hitting the fan, or it could be. Hopefully not.
Yeah.
So, first of all, thank you so much for joining me. It's wonderful to be talking to such an esteemed expert today. I really would love you to kick us off with one thing that you wish more women knew about their hormonal health around perimenopause.
It's such a great question, because one thing I wish people knew is that reproduction and reproductive health is a transgenerational conversation. If we, exactly, if we think about the fact that, particularly us women, when we are in our mother's wombs, we are actually already in our grandmother's wombs. It's kind of strange, but if you think about it, women are born with all the eggs that we will ever have over a lifetime. And that really is what kind of supports the reproductive health that we have and the reproductive window that we are afforded. So the number of eggs that we have will be matured over time. They will be released typically each month. We will get, an egg being released. We will get a cycle, a period, or when a woman is finally pregnant, that will essentially be stopping for a period of time until she gives birth and the process starts again. But what happens and what drives that is essentially the hormonal kind of feedback loops that occur that are driven by the egg. And the egg is also, part of that whole dance that happens throughout the cycle. So if we think about it from the perspective that, okay, as baby girls in our mother's wombs, we already have all of the eggs that we are going to have for a lifetime. That ultimately, if we again take a step back from that and consider that we were already in our grandmother's wombs, okay? So they're like, oh my God, at least 50% of us were already, in our grandmother's wombs, because then it comes down to the father's sperm. But the father's sperm, even though it's matured and processed throughout the father's lifetime, the cells that are going to produce that sperm were also in a grandmother's womb at some point, right?
Oh,
Because
yes.
it will be that whole aspect of the mother creating the egg that's, so we have to think about it from that perspective, because what happens is that the exposures that we will have in our lifetime have begun before we were even born, right? They began in the habits and behaviors of our grandmothers and our grandparents. So when we think about it from that perspective, and we know, for example, the exposure to cigarette smoking or the toxins that are derived from cigarettes, they basically, if your grandmother smoked, they're going to infiltrate, obviously, the environment in which your mother is gestated, which will impact her egg quality, which will impact her ability to gestate children, and so on and so forth. Now, What's interesting, and going back to cigarette smoking, for example, we know that women who smoke typically enter menopause 5 years earlier than their non-smoking
Ah,
counterparts. So
ah,
there is a direct impact of the toxins associated with smoking and cigarettes and fertility and reproduction. But what's also interesting is that it's not the only thing that will be having that kind of impact. Hence why when we are looking at, this transgenerational effect of exposures on our health and our ability to sustain whatever quality of life that we are going to have in the future, yes, it's primarily focused and going to be affected by what happens in our daily choices, but we
mm,
also have to take into consideration those prior things. So what I wish people would understand is that the health of a baby begins not when a conception is already in place or during pregnancy, but it actually happens way before that occurred. So when we think about, sometimes people come to me and they say they may be struggling with infertility, they may be struggling with keeping a healthy pregnancy to term, and they will say something like, oh, why do I have to do all of these things, which is, quote unquote, being healthy, since my grandmother, she smoked, she drank, she did all the wrong things, and she never had an issue
oh,
conceiving. Well, those effects aren't always immediately seen, and they can be seen generations to come. So, and we've seen examples of this with different types of drugs and exposures to toxins like pesticides and, all sorts of things. And the
mm,
the defects, the birth defects that were caused in babies that were born in exposures to, for example, DDT and thalidomide and, all of those
mm,
different types of drugs. So we have we have a sense of that kind of exposure, and we have a sense of what that means. But in our practical day to day, it's usually either forgotten, not discussed to the level and degree that I think it deserves the importance of the conversation. And
mm,
sometimes it's just one of those things that is the attention that's required really isn't given to the matter. That's really what I wish people knew, because if
mhm,
they knew that, it might mean that, in schools, we would be taught rather than be told, oh, if you have sex one time, you're going to get pregnant and you're going to have a baby and it's going to destroy your life. Because that's the narrative, unfortunately, that most high school children these days get.
mm,
They're literally being told, and it's great and important that they're being told about sexually transmitted infections and how to prevent them and all of that. But I think also one of the biggest things that my patients tell me when they've been struggling with infertility for a long period of time is that they wish they knew that getting pregnant would be so hard, as
mm.
opposed to being told that, oh my God, be careful, if you touch a penis, you get pregnant. It's like, well, actually, it's not quite like that. Sure, for a majority of the population, most people in the general population get pregnant without trying. It literally takes 3 conception attempts to take home a baby for most people out there. But the reality of it is that when it comes to difficulty or when it doesn't quite happen like that, there are usually many factors that play a role in the situation,
Mm,
and we're often uneducated about what they are and how to address them. And even women are quite uneducated about their own cycles and their own bodies, but men
mm,
are not even really explained how these things actually work in a
mm.
woman's bodies, even when they are in relationships and even when they decide that they do want to father a child. So I think that those things are important.
Yeah, well, I do agree, and and definitely with this thought of approaching menopause, that was something that I was sorely uneducated about. My own experience was that I was doing all the things that I thought would make me healthy, and that menopause should not be a problem. And then when it was, I really had no frame of reference, nowhere, no way of knowing what it is that I should be doing. Because to be perfectly honest, I thought I was already doing just about everything I possibly could to secure this healthy, hormonal health for the longer term. Now, I suppose for us in perimenopause, there is that intersection where for some of those women, childbearing is something that we put off with careers and, women in education, careers, busy lives. And so then getting to that stage where we're wanting to experience this, glorious gift. And then our hormones really have got other ideas. So it's, it's really can be challenging for people that you really don't expect or anticipate this. And, I actually, the solutions, what are the solutions for women? What are those options that we might have at that time of our lives?
Yeah, look, I think those are great questions. And the first thing that I feel is important for us to outline for people in terms of perimenopause, because a lot of times people just think like menopause, it just arrives one day, and
Yeah.
and it's not quite like that. It really is a process that typically begins 5 to 10 years before the end of a period, right? Before the end of menstrual cycles. So for many women, and there are many different symptoms, and sometimes it's even difficult for people to correlate those symptoms because they don't actually tie in the fact that this particular situation is occurring because of this particular, cause. So in the same way in which, in the beginning, and again, we go back to cigarette smoking because it was one of those things that took decades to be able to really be able to create to understand the relationship between cause and effect, because the damage that cigarette smoking causes can be so slow of such a long period of time that it becomes really difficult to pinpoint, doing that action to getting a particular result. And fertility and perimenopause is similar, because what happens is that the failure of the egg maturation process, which is really not a failure. It's like you're coming to the end of something. Therefore, it's almost like you're running out of, like let's say if you're running out of eggs in the fridge, right? It's not a failure of not having eggs in the fridge. It's just that you've used up all of those eggs. And it's a similar kind of situation when it comes to fertility and perimenopause. But unfortunately, I think that many times the way that this is portrayed in society is as if it's a personal failure. It's as if there is something that is wrong with a woman for having used up all of her eggs, right? And that's not the case. But I think that one of the things that we do need to take into account is this kind of long-term effect that goes on in terms of the change that occurs. And if we understand that, we also understand that as much as, let's say, for example, the typical average age of women reaching menopause may be 50, let's say that. If 5 to 10 years before that, we're looking at, 45 to 40. But if a woman hits menopause or kind of enters menopause at 45, she's really in perimenopause at 40, kind of like, 30, 35 is kind of like that 10 years before. So, and this is where the challenge begins with the conversation of women over 30 running out of time to have a baby, which I despise that conversation. I honestly do, because it puts a lot of extra fear in a lot of women, because they feel like, and it's not the same for every woman, right? It's not the same that every woman is going to hit menopause at 45. And it's also not the same that everyone is going to hit menopause at 50. But also, it's not to say that if you kind of reach menopause later in life, you're going to be more fertile longer. That's actually not true, because what can happen is that process of perimenopause can be that you skip 2 cycles of ovulation, or 3 or 4 or 6, and then you ovulate again. So, if a woman is trying to get pregnant, that obviously is going to have an impact on her ability to achieve pregnancy. If she's trying to be as healthy as possible, she's also going to feel a little bit crazy, right? Because she's like, hang on a second, I don't feel the same as I normally would feel is normal for me. And so, without that learning or that understanding that these changes can be small and prolonged, we start to
Mm.
kind of feel really out of sorts. We don't understand why the changes in our moods just from our hormones. I mean, think about it. Some women have extreme PMS, premenstrual symptoms.
Yeah,
Other
yeah.
women don't,
Mm.
and so what happens is if you have extreme PMS and you're perimenopausal, you're probably going to notice those fluctuations of hormones with greater aggression than a woman who basically is pretty even keeled throughout, her,
Mm.
her
Mm.
cycle.
Mm.
And in addition to that, then we also have other conversations that we would need to have. Is she on hormonal replacement therapy? Is she on the oral contraceptive pill? Are there other factors that are affecting her health? We also know, and this is really interesting, particularly for women in that perimenopausal stage, is that our health parameters in general decline with age, right? So metabolic health starts to become impaired. That's why, sometimes
Mm.
women all of a sudden go and have a general checkup in terms of their blood results and find that all of a sudden they have insulin resistance, or they're pre-diabetic, or they're diabetic, and they didn't see that coming. And the reason they didn't see it coming is because, like perimenopause and menopause, metabolic disease and kind of decline in metabolic health happens on a spectrum over a decade,
Mm.
right? So
Mm.
we start to notice these transitions, not only hormonal, which by the way are exacerbated by reproductive hormones being out of whack, so to speak,
Mm.
right?
Mm.
And thyroid function or dysfunction being more prevalent, and all of these different factors that are kind of all of a sudden, and we think, quote unquote, it's all of a sudden. It has not happened all of a sudden. This has been happening in a really incremental way for a very long period of time. And it just so happens that right now is when we were able to identify that change. This
Mm.
is why, one of the biggest things that I think is so vital for women is to understand that if you go to a doctor and have a blood test result, you are having something that is not quite right for you, to accept oh, everything is normal, just keep trying, for people who are trying to get pregnant, or, oh, everything is normal. If there's some kind of things that are out of balance and parameters that are out of whack, so to speak, but overall it's normal. That is such a big red flag, right? Because I'll tell you one thing, just in the case of women going through perimenopause, if you have a blood test result for, say, your hemoglobin A1C, which demonstrates how well your body is actually working through your carbohydrate usage, and it's a marker of prediabetes.
Mm.
If that's 5.5 or above, already you are going toward a function of metabolic dysfunction, right?
Mm.
If it gets to 5.6, 6.5 is the cutoff in terms of diabetes and the diagnosis of diabetes, for example. But before it gets to 6.5, it will have very incrementally increased over time. And if you're just being told 5.5, it's normal, when the optimal side of that range is like 4.5, well, you're
Mm.
actually leaving a lot of opportunity on the table to optimize and improve your health in the long term. And one thing we
Mm.
know for sure is that if you want to be well at 90, you need to be excellent at 50 in terms of your health, right?
Yeah,
And
yeah, yeah.
that comes down to all of your health parameters, your bone health, your nutrient levels, your hormonal balance, you name it. Like, if we want to have longevity health span that's expanded. All of that is going to come down to how well, how optimally we are living life right now. And if we're not there, it's about figuring out, okay, what are the things that I can actually do that will enable me to improve upon where I am right now? Because if we don't do that, entropy is a certain factor. It's like the time frame in which the system enters chaos and declines in organization within the system, it can be so fast if we're not actually working toward syntropy, toward optimization, toward health. We are going to be, by default, becoming unhealthier by the years. And I think that's a really key thing to recognize.
Yeah. This is exactly my goal, to help people to really unpick how it is that we can maintain this optimal state of health. Now, you mentioned there quite a number of different factors that contribute to this picture: your metabolic health, your hormonal health, and and as you mentioned, the thyroid hormone, that's another hormone in this mix of endocrine function. So, I'm having some trouble unpicking the best places to start with this, because obviously, we, in the UK, we visit the doctor, they tell us we don't need to measure any of your hormones because you're in the age bracket where your hormones are fluctuating wildly, and if we take a reading, then it's going to be misleading, blah blah blah. Well, okay, I understand there's a list of symptoms that direct us to this diagnosis of declining estrogen levels, essentially. So fair enough. However, if we wanted to optimize our health for the longer term, and actually, you know what, for the healthcare system, that's going to be advantageous for them too, isn't it?
100%.
So if we want to do this, which I do, if it's only just me, I definitely want to do it. Where do we begin this? Measuring. I know that in fertility, you really test people. You test all of these different metrics. What should we be testing, and what, in an ideal world, would we be testing, and where are we going to get the bulk of the gains? Where do we direct our efforts to get the bulk of the gains? So I've got low thyroid. I'm 57, so I know that my estrogen's way down there. Where do we aim for?
Yeah, it's such a good question. And I smile as you're telling me about what the doctors are telling you, particularly in the universal healthcare system such as the UK. It's like, you know what, we're not doing anything unless you're dying. That pretty much is the attitude. Unfortunately, through many healthcare systems around the world, and my focus is studying public health at Harvard. I'm doing my doctorate there right now, and it's looking at these differences and these nuances and these challenges that occur literally around the globe. We treat patients at this point, we treat patients in every continent other than Antarctica. So as you can imagine, we have access and visibility to literally every healthcare system around the world. And unfortunately, they are all broken. Like every single one of them. There isn't one that I will say, oh my God, this one is amazing. Patients are unfortunately needing to become more and more educated to be able to deal with their own health concerns, because in a 5-minute consultation, there isn't a lot of time to be asked any question about what is actually, happening for you physically, emotionally, how you're feeling, there just isn't time. And so when I look at the parameters that you've given me, and also understanding what I personally focus on in terms of my health, because I have done this, what I teach my patients, throughout my entire life. Right. I was actually one of my patients. In fact, the way that I got to be one of my patients and be interested in fertility to begin with was because I was diagnosed with polycystic ovarian syndrome at the age of 18. So
Okay.
I was told by a GP, by a specialist, by a obstetrician gynecologist over the phone, you have polycystic ovarian disease and you're probably never going to have children. And that was literally like a 2-minute conversation over the phone. And I was like, oh, that's a kind of weird way of telling a patient such big news, you know? And I thought, okay, what does that mean? Am I going to die? And I had the possibility of asking that, like, am I really sick? Like, what's happening? And he said, no, you're just probably never going to have children. And I'm like, oh, okay. So I better kind of focus on my career instead of, if that's not going to be part of my plan, then, let's just focus on working with other things in my life. And so that's kind of where I focus. And I started working with women's health and reproduction, mostly because I needed to figure out a way of fixing my own issues. My own cycle was totally irregular. I had insulin resistance. I was having difficulty losing weight. It was, this whole kind of conundrum of symptoms that I didn't really know how to adjust. But I started to kind of work on myself, and at the same time started to attract people in my clinic that needed that kind of support as well. And so after about 5 years or so, I started to work more and more with women who had hormonal imbalances. And of course, a natural progression from that was infertility. And, 10 years in, I was doing kind of 50-50 of like women's health, hormonal health, and fertility. And that's kind of how things went until probably I actually proved the doctor that had given me the diagnosis wrong and had my first child,
Oh, wow.
after a natural conception, at the age of 33. And so basically I realized that, well, actually, this is not right. And there's other things that people need to be doing. And certainly there's more that people need to know. And so I started focusing solely on fertility. And then on that point, after I had my first son, I was like, I couldn't work in the same way. So I decided to take my clinic online and do it virtually. And, so since 2013, that's essentially what we've delivered, a telehealth program. But what was interesting and what happened in the following decade from there is that at the time that I started doing that, I started focusing only on people who had been infertile or had difficulty keeping a healthy pregnancy to term for over 2 years. So we started to see more and more like the really problematic side of the equation of infertility. And with that, of course, comes a lot of the women who are at the end of their fertility window and want to know, okay, what are the things that I can absolutely do if this is my last go to give myself the best possible chance of having a healthy baby, or to have the healthiest possible life from here, and ideally a combination of the two, right? So then that's kind of like how this whole thing started in my own clinic and in the way that I work. But what then we started to listen recently in the last 2 years, I've started to kind of dig deeper and deeper, because so many of our patients have then overcame their fertility challenges that were linked to menopausal, perimenopausal symptoms, and then of course are then transitioning into the menopausal area, that I started to look at, okay, what is it that we really need to focus on? What is it that we really need to do from this part now where we're no longer interested in fertility, and really we are actually quite disinterested in fertility, and we just want to be as healthy as possible. And of course, that's the stage that I entered into as well after having my second child, which happened 3 years later. They're now, 12 and 9. So it's like I almost feel like, okay, that part of my life is done, and now focusing on my health overall. And I've been doing a lot of research on this, and looking at, okay, what are the points, what are the real important things that if we as women were to look at, we can actually have a place to be able to optimize, because that's really part of the equation. It's like, yes, we want to know what our body does and how healthy it can be, but we also want to be able to take charge of that process and work towards syntropy, as opposed to just letting it dwindle and be unhealthy. So that has been my focus over the last couple of years. And one of the things that I utilized when I started to realize that, okay, there are things that we can do, was weights training. And weights training has been a revolution in my own life, and I'm talking about like really kind of heavy resistance training with progressive overload and really focused on that. And I've also started looking at the research of the differences between the different types of training, the different, like we're talking about aerobic exercises and the importance of zone 2 training as well as VO2 max, and looking at, what the differences are between those two. I actually found a study this week that I found quite interesting, because sometimes as well as humans, we have this tendency of thinking, oh, we have to do everything and we have to do everything at the same time and we have to do it as much as possible. And so what happens is that then we burn out, because we're like, we haven't even started, but all of a sudden now we want to do like 20 times more than what we used to do. And that can also bring some challenges. But because of this link and this kind of like cross section of metabolic health and reproductive health being so important, because if you can improve and optimize metabolic health, you improve and optimize reproductive health. And just in general, your hormonal balance is going to improve, and your transition through perimenopause through to menopause is going to improve, right? And we see this in mood scales, in all sorts of different types of health factors of women in perimenopause. But this aspect of how our blood sugar regulation, our ability to process carbohydrates, and how that pre-diabetic state usually precedes so many other types of diseases. And in women going through perimenopause, one of the things that we notice is what? We process our carbohydrates differently. We start to have difficulty sleeping, which makes us more insulin resistant. We start to put on weight and, kind of different body changes that we find difficult to shift. Now, what it helps to improve all of those things? Well, actually improving metabolic health improves all of those things. How do we do that? By looking at the tolerance for carbohydrate intake, and that you can measure. One of the most beautiful things that have come out of the last couple of years are the glucose monitors, the continuous glucose monitors, to be able to really look at glucose variation and how that enables us to consume more or less carbohydrate for health and also metabolic health. But also, what are the things that actually make a difference there? And that will be things like your aerobic and resistance training, right? This study that I was actually looking at and reviewing this week, which was fascinating to me, was the impact, the brute numbers of the impact of exercise. There were 3 groups. One group was a control group. They literally were given a pamphlet and said, bye-bye, see you at the end of the study. The second group was given an exercise prescription of aerobic training. It was really, if I look at the prescription, it was very basic. It was like 50 minutes 3 times a week. It wasn't a huge thing. It was really being at the 40 to 49% of your VO2. Your ability to actually process like your carbohydrates is essentially like a fast walk, a little bit of running, swimming if you had joint issues, but like literally 50 minutes 3 times a week was one group. And the third group was resistance training. Similarly, it was 50 minutes 3 times a week. And, when I look at what they were actually prescribing, it was like 2 to 3 series of like 14 repetitions, right? Like 10 to 14 repetitions. Now, if I look at my volume of training compared to that, I look at that and I go, my God, that's like me doing nothing at the gym. But for somebody who's not doing anything, that's huge. And what they also did is that they started to progressively overload over time. Now, how interesting. All of these people had insulin resistance or prediabetes, okay? And what they noted in both of the groups where they prescribed exercise, there was a 69.3% of participants going back to normal glucose levels just from 3 times a week, 50 minutes of exercise. Isn't that incredible? I mean, I look at that and I go, and really the prescription for overall health should be doing something daily, really, whether you're doing like 3 times a week of resistance training, 3 times a week of, aerobic training, and then 1 time a week of a active rest. is ideally what I would prescribe to my patients. And of course, progressively overloading on all of that. What does a progressive overloading mean? Well, essentially, you're making it harder and harder each time.
Yeah.
And how you make that harder, there's lots of different ways. You can slow down the exercise, you can push harder, you can do more repetitions, you can do more sets. If we're talking about resistance training, you can add weight, so there's lots of ways of making it harder. And of course, you will need to make it harder the fitter that you become, right? Because the dose of exercise that you are going to be able to withstand is going to be harder, is going to be heavier, and or more, right? And so basically, but it's incredible because what happened with these participants as well, again in brute numbers, for the ones that had abnormal 2-hour GTT results, the glucose tolerance test results, 18% reduction in an improvement in their glycemic kind of response after that 75 grams of carbohydrates that are just a crazy, disgusting drink that you have to drink. And a 6.2% reduction in just fasting glucose levels, which is insane. There is no drug, these days, yes, there are drugs that will produce that kind of result, but they have side effects. And when we're looking at that, this as an exercise prescription has such a powerful impact by literally you just moving your body more, well, that is absolutely a place to focus, right? So if I was to look at a two-pronged approach to answer your question, I will absolutely be focusing on exercise as a prescription, as a health prescription. And I'll be also focusing on what it is that you're doing in terms of your nutritional intake. So really basing your meals on vegetables and protein. We're looking at protein about the size and the thickness of the palm of your hand at every meal. We're looking at adding a protein supplement. I often encourage patients to be able to understand how do you actually know how much your body needs. And if you go online, you can have macronutrient calculators that will ask you for your height, your weight, and some other parameters, and you will be able to calculate for you what it is that you should be intaking in terms of a healthy diet for women. Now, what's important here, and I think that this is crucial to underline, most of these calculators will usually overprescribe carbohydrates. And when we are in a perimenopausal state, the prescription for carbohydrate should be around 100 to 150 grams of carbohydrate per day, which with a much higher intake of protein, taking into consideration kidney function and kidney health. If your kidney function is normal, it's perfectly fine to go up to the 2.2 grams per kilogram of body weight for your protein levels. It's healthy. It's going to be benefiting you in terms of reduction of muscle loss over time, which is absolutely essential. If you have any reason to believe that kidney function is impaired, you should keep it down to 1.8 grams. And or discuss it with your doctor if he thinks that or she thinks that it should be less. But ultimately, that's going to be where my absolute part of my focus would be going. I'd be increasing fat and fat intake. Good fats, we're looking about polyunsaturated and unsaturated fats, not saturated fats. Certainly avoiding processed meats, because we know there's been a wonderful study that was published in the Lancet recently that talked about the impact of processed meats and sodas and sweetened beverages on stroke and cardiovascular risk for women. And it shows and it demonstrates exactly that, the fact that if you are wanting to be healthy, those foods are things that you do need to address, adjust, eliminate, and or replace with much healthier versions. But, if we're just looking at these very basic parameters already, we have an absolute prescription for good health. And I think that that's something that needs to be taken into account even before, a woman is actually hitting that perimenopausal stage. That really is a prescription for fertility. It's a prescription for good health in the short and long term. And that really is where my focus would be for women in perimenopause. Focusing on those two factors, a healthy diet and a good exercise prescription, is going to make an immense difference on a woman's quality of life and health in the long term.
So well, thank you. I couldn't agree more. Do you have any thoughts or views on hormone replacement therapy in this puzzle of perimenopause?
Yeah, I think that, whatever you see, no no treatment is going to how do I best put this? Is going to replace the need for a solid foundation when it comes to health, right?
Mm,
I think that drugs, any kind of drug therapy, all of those things are wonderful adjuncts to optimum treatment and optimum health where needed, and where it's valid to be able to, like, if somebody is literally sitting on their behind in front of the TV the entire day, eating junk and processed foods, and they think that their symptoms are going to be improved by some anti-diabetic drug or some hormonal replacement therapy without them doing anything, well, I think that's a fallacy.
mm,
Okay, because in that instance, you are actually damaging your health by your sedentary behavior and your poor diet. And irrespective of what drug you take, you're still not going to be able to wipe out that negative effect of your
mm.
behavior. Okay,
Yeah.
so there are two sides to this, which is you must have a solid foundation upon which to intervene. And I talk about this in reproduction and fertility as much as I would talk about it in terms of general health, because the same principles apply. You
Mm,
have to really the body is miraculous and amazing in how it's able to just completely transform and go
mm.
back to homeostasis given the opportunity. Often we don't give it the opportunity that it needs and that it truly requires. Now, for some people, absolutely, hormone replacement therapy will be a godsend. It's going to improve their sleep. It's going to improve their mood. It's going to improve their ability to, like, be sane and function in their life. But it is not a
Mm.
replacement for the foundation that we just talked about. You still need to get off the couch and go and do your exercise and go and eat well so that you can be supporting all the different parameters that are going on with your body. So I think that where women might need it, it's not the only thing that they will need, but it can certainly be a wonderful and supportive adjunct to treatment and to good health, where everything else has been optimized and we're still having some challenges.
Yeah, absolutely. I heard you say, if you want to be pregnant, live like you already are. Uh,
Exactly. Act pregnant
so
now to get pregnant later.
that was it. I can't think of something similar for menopause that's quite so encouraging, but you know,
Yes, I think you just, like, to be honest, I also can't, but I will say this, and I'll tell you what has changed for me over the years is my role models these days are the 60, 70, 80, 90 year olds who are out there slaying it, like they're going to the gym, they're doing their push-ups, they're doing their pull-ups, they're, like, lifting such heavy weights that you would normally kind of go, no, an 80-year-old or a 90-year-old can't do that or
mm,
shouldn't do that. We have, like, this
mm,
societal vision of what a woman should or shouldn't be able to do at a certain age. And breaking all of those stereotypes for me is, like, one of the most exciting things to see, so I definitely want to be part of that movement where we break all of the stereotypes of what women are and what they can be, and certainly, what the future holds for us in terms of ability, because I think that we have not yet even reached close to our potential. As long as we continue to really focus on optimizing health, I think that we are going to see a much changed, and in fact, I think we already have. If you look at women in their 40s or 50s, in the 80s compared to now, we
mm,
already see an incredible difference in how women behave, how they dress, what they're capable of doing, what they're able. And also, if you think about it, like 50 years ago, we had an expected lifespan of 50 or thereabouts, right? It wasn't quite 50, but it wasn't much far from that. Whereas now the expectation, the lifespan expectation has increased so substantially. And it's said, you know, in terms of science, that in the next 10 years, our lifespan is going to increase even further. So, you know, it's looking at, okay, are we going to live longer, but are we going to live healthier? And I think that those two things cannot be disentangled for optimum health in the long term. You know, so however it is that we're going to coin that new phrase of what longevity looks like for women in the long term, I think that it has to take into account the fact that we don't just want a longer life. We want a quality longer life, you know.
Yeah, absolutely. We're in it for the long haul, but we want to be lifting weights the whole time.
Absolutely. And just being able to, you know, like seriously, I don't want to be looking at myself or thinking of myself in my 80s and not be able to actually go travel the world, have, you know, go for a hike, have fun with my friends, my other geriatric friends, or even younger friends, who knows? But, you know, like actually being able to have the function and the ability and the cognition. I often joke, you know, with my friends now and even with my audience in terms of metabolic health, because I've been doing a new project with a wonderful Brazilian doctor. And it's in Portuguese, unfortunately. So, you know, it's a whole, yes, it's a whole different, but it's all about this topic and this conversation of metabolic health. And we often joke, but it's actually a real desire and a real driver that we want to be able to sit on the toilet and wipe our own bottoms by ourselves at the age of 90, right? Because why? To do that takes incredible focus, coordination, cognition, abilities, dexterity, you know, you name it, right? Strength in your legs and your bottom, and, you know, like to sit and lift yourself up from the toilet. Like imagine, like now we take that for granted now. We take for granted sitting and wiping our own bottoms in the toilet by ourselves, right? But I guarantee, and I can tell you right now, that people in their 70s, 80s, 90s do not take that for granted, right? So as much as it's a, you know, might sound funny for a 45-year-old woman to be saying that now, actually, it's my life's goal. It's my dream. It's like, it's what I'm striving towards, you know, in my life. All things being equal, that's the thing that I want the most.
And I think this idea of working our way backwards from, you know, how we want to be in our older age and all the things that you've got to do now in order to be on that trajectory
100%.
to achieve that, then, you know, the thing is, like you said, this thing is long in coming. Menopause is long in coming.
Yes.
It creeps up on you, but you know, we cannot afford to ignore the whispers, and we've got to act now.
And, you know, and I'll add this, and I think that this is a very personal, you know, situation. My dad has been going through cancer treatment for the last 5 years,
I'm
and
sorry.
it has been, yeah, it has been very difficult to watch, you know, from how he was initially, it was a prostate cancer that was kind of like treated, and 15 years later, he then ended up with colorectal cancer, which has now gone everywhere from liver to lungs to brain. He's had, this year alone, he's had a brain surgery to remove a tumor. Then he basically he was about to go and start his next 12 rounds of chemotherapy, IV chemotherapy. And in the PET scan leading up to starting his chemotherapy, they saw some calcification. So he went to the cardiologist to go check, you know, and do an angiogram to figure out if they needed to put a stent or what needed to happen. He gets to the angiogram, and the doctor who's doing the procedure says, "We won't be able to put a stent. I'll be back." Gets out of the room, comes back with the surgeon, right? And to tell him, well, actually, Mr. Rosa, you are not leaving hospital today. We need to do a quadruple heart bypass. So he literally was like, okay, I was going in for an angiogram and maybe a catheterization. And now I am staying here for the next 12 days to, kind of undergo a open heart surgery in a 73-year-old man who basically has already been going through 5 years of chemotherapy and all sorts of surgeries and all of those things. Long story short, fast forward, post, and he survived. Yay, amazing. Guy is like a trooper, because like, who has a brain tumor removed and then goes for a quadruple heart bypass and literally is just walking around like, it's another day. And I'm like looking at it going, oh my dear Lord, this man is like so strong. But what was fascinating last week, he started to not be able to walk very well and to walk very far. And he was having, some swelling in his feet and all of those things. We figure out, in that moment, like coming back to this conversation, how much do we take for granted? Just the ability to be able to get up from your bed, to go to the dinner table, to sit down, to get back up, to go to the toilet by yourself. Like, we take that stuff so for granted. And in the last week, he literally was not able to stand up by himself, to go and do things by himself. They found out that he had 2.5 liters of water in his lungs that had to be drained. So it's like, it's those kinds of things that we really feel like we take so much of our health and life for granted. And I think that has to stop. We have to be able to look at things and realize that it's not always going to be how it is now. And if we are to have a better future and a better life and better health, we need to be really, really proactive. And now, if the story of my dad inspires anybody else to go and have their colonoscopies and their endoscopies and my dad delayed doing that for 15, 17 years because he was embarrassed to have a colonoscopy. You know what? Like, he says it himself now, he wishes he had done it sooner. Well, now it's too late. So unless we really focus on being proactive about our health at the first stage of things not being quite normal, that we are ready to act, well, you will probably end up like my dad. And it's avoidable. It's avoidable. That's the key takeaway. I think that people need to become way more proactive than they are in terms of optimizing their health and seeking synthropy, as opposed to allowing themselves just to have what is the default, which is chaos in the system and entropy.
Yeah. Well, thank you for sharing that. It's definitely the case that lifestyle medicine is powerful stuff. We underestimate the value and the impact, and you demonstrated that with the studies that you described. The impact of doing these, what on the face of it seem like simple things, but very effective,
very powerful.
Yeah. And so
very powerful,
take
and
your
within
life.
our reach. Right, within our
reach.
control, within our ability to actually action. That's the great thing about it.
It is, and so much of this stuff is free. So
exactly.
It's a no-brainer if you ask me. Well, Gabriela, thank you so much for giving you time today to chat with me on the podcast. We've covered a lot of ground, I must say, and so it's thank you for doing this amazing work and speaking to lots of different podcasters. I know you're very you're here, there, and everywhere with this, spreading your message of health and wellness in midlife and beyond, and from the cradle to the grave.
Absolutely.
So thank you so much for coming along and having a chat today. I will put the links in the show notes so people can find you. And I look forward to following and learning more about all the work that you're doing. Thank you so much for coming along today.
Amazing. My pleasure. Thank you for having me.
Thank you. And so it's bye for now. Take care,
Bye.
everyone.